So next topic, postpartum period. I had posted this on a few social media sites. The postpartum period should be redefined as at least 12 months after giving birth, if not longer, rather than the traditional 6 weeks. Your mind, body, and spirit are never the same. And I think most people agreed on LinkedIn, Facebook, Instagram, and there are a few bashers as usual.
What is the postpartum period technically?
So, let's look at from obstetrician point of view. Usually patients are seen 6 weeks after delivery. How it came about, hard to say. Physiologically, if we look at the uterus, becomes from pregnant, gravid uterus to non-pregnant size from about 1 kilogram or 1,000 gram to about 60 gram on the average over the course of 6 to 8 weeks. So idea that whether it's 6 or 8 weeks, your woman's body kind of goes back to the way she was, which is never the true case in many people. But what I was trying to say was mainly to give support for women after giving birth. And as you know, we are probably the only developed country without mandatory paid maternity leave. You go to Canada, you get, I think, 52 weeks. You go to Mexico, you get 12 weeks. Almost every country in North and South America and Central America, you get some weeks off paid. And here you get 12 weeks off, but it's not paid.
I think that's recently changed, actually.
I'm not sure if it's paid. Maybe it has.
Yeah, I think it just recently changed.
In Massachusetts?
In Massachusetts, yeah. Because there's a fund now that we pay into as employers that goes into that process. So there's a built-in payment.
And I would say that for a lot of small business owners, that's a huge burden, right? Yeah. I mean, 12 weeks is 12 weeks. Yeah. However it comes out of whatever. But
so to me, the postpartum period is like you have a baby.
Mm-hmm.
There's your prepartum.
Yeah.
There's your partum.
Yeah.
There's your postpartum. And then, so how does this figure right now?
The point I was trying to make was that as a society, we're not supporting women, not just the physical, but I think that we need to give them support longer. And also, of course, we have to consider male figure too, right? Or partners, to be more politically correct.
Partners, yeah.
And it's not there. And it's a huge problem. And that becomes, it is related to you too, right? Pediatric component is significant here. If a mother has not recovered well during her first 6 weeks, and if anxiety, depression, and whatnot is involved for the mother, then certainly how she provides care for her newborn through you is going to be affected. Maybe maybe you have some patients who is not keeping appointments. Maybe there's an issue, So I think it's a huge issue that, like many things in women's health, there's no easy solution, but we have to bring it up, address it. And I think there are some big companies, Amazon, Facebook, big giants, they give really good support. I mean, I think some of them give like a year off and whatnot.
So tell me, because it's because when the baby comes to us, it's in our realm, and we are involved in the maternal side and paternal side a lot. But after a mom has a baby, they come back. If everything's fine, they see you. When do they see the OBGYN again? And then after that,
and here is where money is involved. So we are paid as a part of global. So whether you are seen 10 times or as long as you are seen 7 times or more for prenatal period and delivery and postpartum all bundled into one, we get a global fee. So a lot of doctors say, well, we're not going to get paid for postpartum visits, so why see them before 6 weeks? So most OBs will not see their patients for 6 weeks after delivery unless there's a problem, unless there's hypertension or some unforeseen problems.
So are all OBs paid that way, or just across the nation?
Yeah.
There's a global payment.
Global payment.
Like so you get one fee.
Yeah.
So say you saw someone 7 times, or say you saw someone once, you get the same.
Well, not once, but 7 visits or more.
Okay.
7 visits or 17 visits, the same.
Really?
Yeah. So a lot of offices don't do that. For the longest time, what I do is I see them every 2 weeks until they are well. Usually by the 3rd visit, by 6 visits, I can tell they're doing well. If I happen to put them on, say, anxiety medication or depression medication, then I may do another month or 2. I follow them, but I tend to do visits which I think are medically necessary, but not financially.
And this is post or pre?
Postpartum.
Interesting.
Yeah.
So after the 6-week visit,
yeah,
everything's fine. You know, everything went smoothly. Do you see them again after that?
After that, probably a few months after, because that brings us to their annual exam, about our annual exam cycle.
And when do you like? What's the line between you and their primary care doctor? Like, is there a handoff there? Is there like a smooth transition? Or are you working in symbiosis? Like, how does that work?
Well, I mean, my practice probably is different because most of my patients are not referred from the area, so I don't really have such relationship with the primary. And most of my patients tend to see me for their annual exam. There are some patients who see their primary for annual exam.
And you say annual, it's like their female exam.
Yeah. Breast and pelvic and other psychosocial.
We'll just say female.
Female
exam.
Yeah. Female exam. Yeah. Which you do, don't you? Do you do that?
We are all able to do it. I trained to do it, and I did do it when I first came into practice. But I don't do them as much myself anymore. But the nurse practitioners that I work with and my female colleague do them. We do. If needed, we would do routine pelvics, or other exams depending on what the situation is. But the answer is yes. And a lot of practices don't. Yeah. But we do. Yeah. And we do a lot of contraception stuff and menstrual cycle irregularities. But yeah. So when you had made this post, which is I think a strong post, like the thing that popped into my mind is postpartum depression.
Yeah.
And we are really, as pediatricians, we try to be all over that. We feel that that's our job and that's in our realm, and we screen every mom that comes into the office.
Do you do?
We do. We do a
interesting.
We do a a depression
EPDS?
scale. Yeah, EPDS, the Edinburgh depression scale. And every patient, every visit, at least every well check. The initial one, the 1 to 2 week check, the 1 month to 2 month. That's part of all of our checks.
Is it typical of other
It's a great question. I don't know.
I don't think that is.
I think how we're affiliated with the group that we're affiliated with, that we all all the groups in that affiliated practices do it. And I didn't do that before actually at my prior
because
practice.
I do that.
I'm sure you do.
I do it depending on risk factors. I may do as early as 2. Yeah. Sometimes I may do 2 or 3, but definitely by 6 weeks.
Yeah. And it's really important and powerful to do that because I think the only people who are really looking at these moms, talking to these moms, and we can talk about the dads too, which I think should be part of the screening process, us and the OBGYN, so some parents haven't connected with their PCP yet, after the delivery, or they don't, it's tough for them to get in to see them, urgently if they're feeling down or low. And someone's got, and it's our responsibility as providers that we take care of the whole family. I'm lucky, this is a nice vignette, but I'm lucky in my office because we also have ancillary providers. We have psychiatric nurse practitioners in our office.
Great.
And one of the psychiatric nurse practitioners who is a nurse practitioner who also has a higher level of psychiatry care, she's basically like a psychiatrist. She takes care of adults too. And I've had moms in the office who were clearly depressed by our scale or had depression before, and it came back because they were off their medicines, or anxiety, and they weren't able to connect with their PCP. And I was able to facilitate a evaluation with her in our office and get them on medicine quickly and stabilize them. And, I think, we should all, I mean, we're lucky to have that, but I probably would have done it myself. I mean, I take care of young adults. I mean, this mom needed the medicine, but I think it's really important. Like when you said this, this postpartum period, that's like this nebulous, this black hole time where they may not get the care they need, if they can't get back to the OB or the PCP. And I think it's really important to envelop them,
Because some of them may be able to express their concerns through these surveys because they're comfortable with you or with me. Some of them may not be, and they may not be able to express such concern until many months after.
Yeah.
And I have had patients who are still struggling with something that may have happened during labor and delivery, even after a year. So the issue is then, who do they see?
Mm-hmm.
And the one thing you hit from our conversation is, I mean, there are a lot of good PCPs, but there are also a lot of PCPs who are not receptive to this kind of scenarios, which means patients are not able to really connect with them. So as you said, after 6 weeks to a year, we're talking about 10 and a half months.
Mm-hmm.
Who do they go to? And we talked about obesity. Obesity and anxiety and depression, they're all related, right? Mm-hmm. Which one, what's the first, egg, the hen or chicken or whatever? Yeah. It's all related.
Yep.
So I think, and we're using social media as our tool, but social media may be at fault too, because people use social media to compare themselves to their friends, neighbors, and whatnot. And depending on how things went well, it may not always be positive to look at themselves or their friends.
Well, just think, say you have a PCP, a primary care doctor.
Yeah.
You see them once a year.
Yeah.
Once a year. And that's your only interaction with them, your touch point, as I like to say, with your doctor. That's great. You're healthy. You see them, and then you're pregnant, and you're having your baby, and they see you, and then the baby's born, and then they see me, and then they get depressed. Who are they going to reach out to first? The PCP that they're seeing once a year, who might not even know them that well. They're going to reach out to their OB, who knows them very well, or hopefully, reach out to us, or we're asking those questions. And it's like almost like we're on the front lines. And like you said too, the secondary effect a depressed mom or anxious mom can have on the health of her baby and the way she can take care of the baby and the cycle of that, how it affects her and it can be so detrimental that it's like driving by an accident, right? As physicians, we stop, we have to help, we're obligated, you got to get in there and help these people.
I mean, I was telling patients today that I wish I had time to see a patient maybe over like 2 hours to really get to know her, really address everything. And I talk a lot. Even with that, I don't think I'm really getting to them. But PCPs, the way it is right now, the way it is structured based on financial needs, do not spend enough time with their patients, period. Whether it's the physician, nurse practitioner, or PA. I mean, I think it's true that many NPs and PAs may have better relation with their patients because they are allowed to spend more time with them, perhaps. But the current structure doesn't work. It's just, there's so many issues, whether it's for 50-year-old guy or 50-year-old women about menopause, or menopause, the issues we deal with, or 30-year-old dealing with diabetes, hypertension. The current structure doesn't work. The whole thing. I mean, this is when I say the current healthcare is total shit show. We're doing our best because we are in private practice and we care and we spend, time that other people don't spend.
Well, I strongly feel there are some good practitioners out there, but I think overall, the way it's set up, if you don't really try harder, you set up to fail. You set up to fail.
It doesn't work.
Because I can tell you, my PCP spends some great time with me, maybe because I went to med school with him, maybe because he knows me. But I think he does that with all his patients. He also runs a little bit behind because of that, but that's okay. I get that. But I think that, just think about my mom who has a very good PCP at a teaching facility, hospital. She has a cough. She doesn't feel good. She calls them up. They say, we don't have time today. You should go to urgent care. That's That's the answer. So say you're a depressed mom, just had a baby, and you call up your PCP and say, I'm depressed. What's the answer? Are they saving that time for them? I don't know. But I think
no.
I know. I think that the system is broken in that way. So it's interesting, like you spend a lot of time with the patients. I hopefully do too. And what I find isn't as much, it's not as important how much time I spend with each patient. It's how accessible I am when a patient needs to see me. So if a patient says, I need to see you tomorrow because my son needs to see you tomorrow because he's having emotional issues, I'll see them tomorrow. I'll fit them in. I might not have an hour to see them on a certain day, right? So it's all how you balance your thing. I think we have to have the time, and we have to be accessible. And if you don't have the time, or you're not accessible, you got to make yourself accessible.
I'm in a unique situation, maybe different than other specialty, in that in a typical pregnancy, I see them 12, 15, 16, 17 times. I get to know them, and especially last month, I see them weekly, if not twice a week, depending on medical condition. And then I am involved with my patient, do the delivery, and I see them soon after. And I feel in most cases, I'm able to catch if there's anything concerning. And I tell you what, I was telling a few patients today, the way I practice right now, which is very demanding because I am at their mercy through my mobile number, which I was getting text as I was talking here. But I don't know if I could do it any other way because it is such an amazing life event, right? Growth of a little one in one's belly to delivery and after. I don't think I could. I mean, the way my plan is, I'm going to do obstetrics this way, my way, the way I've been doing it, until if it becomes too much, I'm just going to close the shop and not just
walk off into the sunset.
Walk off. Just do GYN only.
Yeah. The postpartum period.
Bottom line,
is there an end to it, really? Right.
Right. I mean, one gentleman said, my wife would tell you it's a lifetime, which Charlie is true.
Yeah.
But I think when it comes to healthcare, here's the bottom line. We have the resource in this country. We just have to reconfigure. The blame also has to go to people. Speak up. If you don't like Dr. X or Y, Z hospital, then don't go to their practice. We do that with everything else. We don't do that with medicine. So you have to speak up, and if you demand, change will be made. But I understand that, I take my share of blame and you will too. But it's not just us, it's people too. But the way it is right now, I don't know, man. I mean, when I get old, I'm not sure if I can depend on anyone to take care of me. I'm just going to have to die in my own farm.
I'll be there for you.
You'll be there
Become
for me.
full circle, right?
Yeah, change my catheter.
Start in diaper, end in diaper. I'll create you in my arms, John.